So, hi everyone. My name is Phedias Diamandis, and we're continuing our developmental neuropath lectures. Today, we're talking about forebrain malformations and really focusing on midline pattern and defects. As always, these lectures are meant for educational purposes to discuss the kind of fundamentals and the embryology that surrounds important neuropathologic conditions, but these are not meant to be of clinical or diagnostic use. So please consult your doctors for any medical advice. But hopefully these will provide some background to help provide some foundations about the principles of these neuropathological conditions. So today we're going to be talking about midline patterning defects. We're going to be focusing on a group of disorders that are somewhat linked at the midline, as the name suggests. We're going to focus on holoprosencephaly and then also touch on some related disorders such as atelencephaly, aprosencephaly, agenesis of the corpus callosum, and septo-optic dysplasia. I have two other lectures on our channel on migrational disorders and hemimegancephaly and epilepsy that can also accompany this to round up other forebrain malformations. So these are some of the books I've used to create these lectures. Each book provides different strengths. Some are stronger in the embryological descriptions. Others have more pictures. So you really need to take bits and pieces of different textbooks to kind of see the holistic view of these rare conditions that most often only have a handful of reported cases in any given discussion of their neuropathology. So this is a nice image I found online that kind of shows the different neuropathological features of these conditions, and we'll talk about them as we go along. But really, they lie along a spectrum from very severe, such as aprosencephaly and atelencephaly, to less severe holoprosencephaly, which is also quite severe. And then you have more subtle defects such as agenesis of the corpus callosum and septo-optic dysplasia, which are much more subtle and have much more subtle clinical findings. So to understand this topic, it's critical we understand some embryology of how the midline structures are formed. And these are complex topics. So I've included multiple cartoons or schematics of how the brain forms, but these may require some thought and repetition to fully understand. And some of these are not fully understood yet. And so if you do feel there are some missing links, you're not alone. So forebrain patterning is really driven by midline signaling centers. And it's not to say that the midline is the only portion of the forebrain. As we'll see, it's just the one that initiates the cascade of events that lead to the entire formation of the forebrain. So it begins at these extraneural sites. So this is the kind of embryonic plate that has these three layers. We're looking at it from above, the ectoderm, mesoderm, and endoderm. So we're looking at from the from above, the ectoderm, and really you have this primitive node or Spearman organizer that starts really initiating the development of the nervous system by secreting anti-BMP signals that are important for the ectodermal development. And by doing this, it stimulates the formation of this notochordal process that will continue to grow rostrally to this prechordal plate. And this also has some BMP signals. And really, this is what's going to stimulate the formation or the buckling of the ectoderm and formation of this neural tube. What we'll see, one of the key principles in these in the embryology is this concept of homeogenetic, which is basically that um, similar structures based on their spatial coordinates secrete similar morphogens. And so you have this kind of amplifying um, and spatial temporal pattern of these signals that kind of feed off one another to organize the ventral, dorsal, and rostral component of the brain. So these extraneural sites are really important for gastrulation to neurulation, right? So the formation of that neural tube structure that we see here with the primitive node and the notochord being those extraneural sites in the mesoderm. And again, the key one here that starts everything is this Spearman organizer, also known as the node. This will secrete anti-BMP signals such as chordin and noggin. The ectoderm really has a lot of BMP that helps form the skin, the ectoderm. And by having these sites release anti-BMP signals, they allow that ectoderm in the midline to form this neural tube structure. Um, Again, once this kind of gets the ball rolling, these BMP antagonists get transitioned to being released by the notochord and the precordial plate, which are these structures here, right? And then again, they're going to secrete sonic hedgehog as well, and start ventralizing the brain and the neural tube into a ventral and dorsal component. And those are going to form different structures of the forebrain. The epidermis, as we talked about, is secreting BMP downward. So there's a gradient of BMP with high concentrations on the ectoderm and the dorsal part of the neural tube, and then the notochord is secreting sonic hedgehog from ventral to posterior. So high concentrations of sonic hedgehog there. While this is going on, again, there's more transition and passing of the baton of these morphogens to neural centers. So as you can see here, the sonic hedgehog is going to transition to the floor plate of the neural tube, and this is going to become the ventral-telencephalic midline region. And then the BMP signaling is going to transition from just the ectoderm above to the roof plate. That's going to secrete BMP as well. And this is called the dorsal telencephalic midline. And then at the very top of this neural tube, the rostral component, anterior ridge, as you want to call it, anterior neural ridge is going to become the rostral telencephalic midline. So now you have these three major centers secreting, as we'll see, different morphogens, and they're going to give the brain not only direction of to grow in size, but also to have some positional polarity and really form different components of the brain. So these are the three key centers of the telencephalic development. But really, the key point is that they really began in that midline with the notochord secreting sonic hedgehog, as we'll see. Although these are primarily midline defects, the amplification of these different morphogens that come one after the other affects the whole telencephalic development altogether. So here is another diagram. I feel like each diagram offers their own unique insight into how these structures are made. So now we're looking at it from the side angle, and you can see that it's not just a hollow tube, but really the tube is folded multiple times over, adding to the complexity of trying to understand these concepts. So we have this anterior neural ridge, or the rostrotelencephalic midline, that is secreting FGF. Ventrally, you have this sonic hedgehog secreting um, ventral plate secreting sonic hedgehog, and dorsally you have there's roof plate secreting BMP signals dorsally, and then wind is also a factor that leads to the dorsalization of the neural tube, and then all these again combinations will lead to different components of the brain. So here's the one from the main book that we're focusing on, developmental neuropathology. Here we have the um, we have this um, rostral component. The green here is secreting FGFs. We have the sonic hedgehog being in the midline, and then the BMPs and Wnt in the back. And really the goal of the anterior visceral endoderm, which really is the rostroneural tube, will secrete signals that antagonize Wnt. And Wnt is a cartilization factor important for the back part of the brain. And so by the anterior neural ridge secreting these anti-Wnts, it really allows, it tells the brain this part of the brain is going to form the forebrain, or the front part of our um, uh, cerebral cortex. So again, there is a spatial temporal component to these that begin with nodal signaling from the nodal cord and the precordial plate. And the precordial plate is in that kind of oral pharyngeal area in the front of the face, and is secreting sonic hedgehog. Why this is important, as we'll see, is that not only is it patterning the brain, but it also has a role in patterning the facial structures and the bones, and how things get divided in the midline. And so as we'll see, there is a correlation between the face and the brain, and that precordial plate release of sonic hedgehog and nodal is going to play a key part in setting the stage for the correlations between the face and the brain. As we said, signals get passed to the ventral telencephalic midline, which is going to be it's going to be an important part of ventralizing the cerebral cortex. Some of the things it does is that as we said, this neural tube is folded, but things are moving dynamically during development, and so the hypothalamus, based on these signals, will move downward as other structures grow, and then this helps split the eye fields that really begin in the midline as one eye, and then get split and go laterally as shown here, and then they're going to move up. So all these things are moving simultaneously together based on these morphogens. And as we can see, as we'll see with holoprosencephaly, when this goes wrong, we see good evidence for that in the autopsy specimens. Interestingly, the eye fields begin below the nose, the nasal placode, which is going to form the nose, and we'll see what happens when the morphogens don't instruct the eye to not only split but also move rostrally towards and kind of displace the nasal ridge, so they're above the nose. And one of the kind of pathologies in holoprosencephaly, as we'll see, is a cyclopia, so one eye, but also a structure known as a proboscis being situated above the cyclopic eye. So a lot of things going wrong with not only the induction, but also the positioning of these final structures in the kind of normal face anatomy. So the ventral telencephalic midline will then again assume the role of secreting sonic hedgehog, and it'll lead to the ventral forebrain. The anterior neural ridge will assume the role of the rostral telencephalic midline and secrete FGFs, and really help develop the rostral component of the forebrain. and then the ectoderm will pass those signals to that roof plate or the dorsal telencephalic midline and secrete BMPs to dorsalize the neural tube and form the dorsal forebrain. The key to all this is that these are not just working in isolation, but rather they form these loops. And so nodal signaling in the precortal plate will stimulate sonic hedgehog, which will then activate FGF signaling in this anterior neural ridge, which will then have other effects on BMP, both as activating and inhibitory. And it's these kind of signaling cascades that not only drive the facial development, but also drive the patterning of the remainder of the forebrain. And so if one of these things go wrong, not only do you get a face and a brain with incorrect anatomy, but it doesn't allow the brain to also grow to its appropriate size, as we'll see. I included this picture because it again it provides something unique. In the fourth week, we have this we see this third ventricle being formed at the top of the prosencephalon, and you can see how thin. It's basically the top of the neural tube. It has a very thin distance to the ectoderm. And then as the midline patterning gets induced, you see that these telencephalic cysts of the neural tube really take over and form the forebrain as we know it with these lateral ventricles, but also increase the mass of the tissue. And so what we'll see with these holoprosencephaly is that there is a cyst, the characteristic cyst that forms, and that cyst is really just the thin lining of the neural tube because of this failure to create enough of the cortical tissue that basically pushes this down and prevents that cyst from forming in the normal brain. As we mentioned, these signals are working cooperatively together. So the ventral sonic hedgehog signaling in the third week of gestation cooperates with dorsal BMP signaling to kind of change the dynamics of the speeds of how the different components are proliferating. And the forebrain will grow slower than the ventral forebrain will grow slower than the dorsolateral components and lead to those balloonings and outpouchings of the telencephalic components. And so when these are not coordinated, that positive feedback loop that leads to this can't occur, and you just don't have telencephalic development. So another key, as we mentioned, as we'll see, is really key to this disease is the role of sonic hedgehog for some of the facial structures and some of the ventral components of the brain. So sonic hedgehog is important in inducing this optic primordium in the midline to kind of divide into two pairs of optic vesicles and form eyes on each side of the brain. And so when that doesn't happen, we'll see that you get very severe neuropathological findings. Other midline structures like the olfactory bulb and tract are also dependent on appropriate midline signals, and not just in holoprosencephaly, but across all the diseases we'll talk about today. We see that the olfactory bulbs and associated cortical regions do not form when there is defects in midline signaling. So here's some other pictures to kind of visualize this. We have the floor plate. So this is the ectoderm. We have these folds of the roof plate. The floor plates receiving a sonic hedgehog from the notochord below it. The roof plates are that are far from the sonic hedgehog signaling do not have any. So they have presumably a BMP rich, and they will be induced to fold and form the neural tube. And then you have this anterior neural ridge that's secreting FGF that's going to help provide some spatial coordinates to the forebrain development. And so the major areas are this FGF signaling, the sonic hedgehog here in the ventral component, and then the BMP and Wnt in the kind of hem area that are going to provide some coordinates for the brain. And then here, if you've missed the lectures that show how the neural tube actually forms, these neural ridges will will rise to fuse together, and the ectoderm becomes this neural tube that's going to propagate these BMP and sonic hedgehog signals. You also see that laterally there are some additional signals such as retinoic acid that are being secreted by mesodermal structures, but that's not the focus of this talk. So yeah, hopefully grouping these different cartoons together will help you understand the kind of spatial temporal pattern of how these structures are formed. And here are the kind of five mature vesicles. I think I have another photo of this, but really the prosencephalon is going to divide. You start with three major vesicles: the prosencephalon, the mesencephalon, and the rhobencephalon. The mesencephalon stays as one single vesicle. The prosencephalon will divide into these major outpouchings, the telencephalon, that are going to form the major components of our cerebral cortex, and the diencephalon is going to form the kind of basal ganglia, midline structures. There's some further division in the rhobencephalon. Again, not relevant to this discussion, but really it's the failure of this induction, both the midline and this kind of maturation and expansion that underlines these disorders. So let's get right into it. So holoprosencephaly, this is a defect of midline induction. So there's a failure of these vesicles to identify where the midline is, and again, problems arise from there. There's different severities that lie on a spectrum. They've been kind of grouped for simplicity's sake into three major groups: lobar, semi-lobar, and alobar holoprosencephaly. But it's important to note that this is a simplification, and really these should be considered a continuum. So as this image shows, they're accompanied by extra CNS malformations of midline craniofacial structures, including cyclopia, cleft palate, and nasal anomalies, which we'll talk about shortly. But there is also, as we'll see, a great heterogeneity within families and severity. And there is what's called a microform holoprosencephaly, where there are only craniofacial abnormalities without significant or appreciable brain defects. So, and we'll see why that's important, because it has important for genetic testing. In most cases, as we mentioned, face predicts the brain. Obviously not in the microform type, but in most cases, the increased severity of the facial structures suggest a higher severity of brain pathology, but that is only in 80% of cases. You may have a normal facial structure with some neuropathology, and vice versa. So not something that's definitive. So in live births, it's about 1 in 0.5 to 0.89 per 10,000 live births. A relatively rare disorder, but in aborted fetuses, it's about 1 in 250 conceptions. And just to give you an estimate, this is about 5 times higher than neural tube defects that we already covered, probably because of the preventative measures of neural tube defects with folic acid administration. But this is something you're going to see more often than the neural tube defects. Alobar holoprosencephalies, they usually die in infancy, but semi-lobar and lobar holoprosencephalies usually survive into adulthood. So you could get specimens later on in life if if they're one of these less severe forms. Risk factors, maternal diabetes, and as this picture shows, an interesting kind of historical observation of the disease was an outbreak of cyclopia in lambs born to ewes, or I guess adult lamb that were grazing on Veratrum californicum, which contain this cyclopamine compound. And interestingly, this cyclopamine compound inhibits the sonic hedgehog signaling pathway, which, as we mentioned, is the key driver of this midline patterning. And so, a kind of a chemical risk factor for animals than for humans, as we see here, where you can get defects in midline patterning, possibly cyclopia. We have this proboscis here, which should be the nose under the eyes, and then maybe a cleft lip here with the tongue sticking out in this baby lamb that was whose parents were eating this California corn lily during conception. So again, going back to these brain vesicles, why do we call it holoprosencephaly and not holotelencephaly? Well, it's because really there is a failure of induction of the midline, and these signals that contribute to sonic hedgehog signaling also are the ones that induce FGF from the anterior telencephalic midline or rostral telencephalic midline, and then subsequently help pattern the dorsal telencephalic midline. And so if you have a defect, you really have a failure of induction of these telencephalic vesicles. And so what we're seeing in the pathology is really this in the severe forms, not the telencephalon. It's really a failure to go to this 5-vesicle secondary brain vesicle structure. And as you can see, again, there's folding of these things as the brain develops, adding to the complexity of trying to understand the spatial coordinates of these different defects. So genetics, most are sporadic, with most cases having an identifiable genetic etiology. So 50% of them have cytogenetic abnormalities or chromosomal abnormalities. These are chiefly trisomy 13s, with 67% of trisomy 13s having neuropathological features of holoprosencephaly. So that's really the kind of main genetic defect. I think you may get asked on a board exam, for example, just because of the high prevalence or connection of those two genetic and neuropathological events. Triploides also have a kind of a high incidence of holoprosencephaly, with trisomy 18 making a very small portion of those cases. So there's 25 are syndromic, so they may involve other organ sites. Pseudotrisomy 13, again, something about the chromosome 13 that makes you at risk for this disease. And then there's a number of syndromic syndromes that have holoprosencephaly as their finding. I really only touch about Smith-Lemmy-Opitz syndrome here, just because of the interesting association with the mutation that it's involved in is in cholesterol biosynthesis, which, as we see in this picture, is a key component of sonic hedgehog signaling. Sonic hedgehog needs cholesterol to bind properly and inhibit this patch receptor. And really, the patch receptor is through cholesterol biosynthesis inhibits smoothing. And so, without cholesterol, if you can't inhibit the patch receptor, you're not going to be able to relieve the suppressive effects of patched on the smoothened transmembrane protein, which really turns on the sonic hedgehog pathway. And so defects in cholesterol metabolism affect sonic hedgehog signaling indirectly because of this, the way sonic hedgehog signals. So 5% of mutations, if you don't have a chromosomal abnormality, you could have point mutations or deletions, and usually those fall into four major holoprosencephalic genes that each make up about 5% of cases. And these are shown here in red, SIC3, sonic hedgehog, ZIC2, and TGIF. And these are really the four key genes that get that midline signaling cascade going. And so if you don't have these transcription factors, you just there's a failure of proper signaling of this pathway. Um, Interestingly, mutations in sonic hedgehog are more commonly form this microform type of holoprosencephaly, where you can have uh, the um, the facial abnormalities without the necessarily the neuropathological findings, and ZIG2 tend to be the de novo cases that don't have a familial pattern. So all these mutations are autosomal dominant. They behave as autosomal dominant through a haploinsufficiency type of mechanism. So having some sonic hedgehog is not enough. You need the appropriate dose. And that's what haploinsufficiency means, is that just having a defect in one of your two genes is enough to reduce the amount of sonic hedgehog signaling to a point that improper midline patterning happens. As we said, other mutations include cholesterol metabolism, um, and 1% of mutations occur in other holoprosencephaly genes. FGF8, again, we know that this is the one that is at the rostral telencephalic midline, responsible for brain development. And then there are other genes involved in sonic hedgehog signaling, this patch receptor, which inhibits sonic hedgehog, and also GLI2, which is a downstream transcription factor of this pathway. And so you can just see how important this pathway is in these types of disorders. The remaining 9% of these cases tend to have some sort of environmental factor, whether it be infections, diabetes, fetal alcohol syndrome. And so in these cases, there may not be a genetic event that is identifiable. So clinical features, this is a disease of autosomal dominant with variable penetrance. So even if you are in a family that has these genetic events, there is a variability in penetrance. Some people may have a severe form, other people may have a less mild form. Common issues, hydrocephalus, presumably due to the apparent fusion of these midline structures, where there's usually some sort of conduit of the third ventricle to the fourth ventricle, the cerebral aqueduct. So if you have defective midline structures, you may create some sort of bottleneck there and lead to hydrocephalus. Epilepsy is common, as we'll see. These brain vesicles really generate the majority of the cortical tissue around the ventricles. So if you have defects in induction, you're not going to have the proper neural circuitry, and you could have epilepsy, motor and oral motor impairment, endocrine dysfunctions, and other kind of midline organ with hypernatremia, adrenal hypoplasia, hypothyroidism being common, developmental delay, and there's also what we learn about the autosomal dominant pedigrees is that carriers from these families, 37% of them may have holoprosencephaly, 27% of them have a microform type where they have some facial abnormalities, but no clinically apparent features on their brain structures, and then and then and then 36%, so a third will have normal intelligence with no clinical abnormalities. And these are just asymptomatic carriers within the families that have a variable penetrance, right? But can still transmit the disease to their offspring. So family planning very, very important for these familial pedigrees of holoprosencephaly. Diagnosis, you can diagnose on prenatal ultrasound. You can see a monoventricle, fused basal ganglia. In this case, we see the proboscis, and then here's another case where we see the kind of fused basal ganglia, the monoventricle, and um, other abnormalities that may be diagnostic for these disorders. So pathology, most of the defects are greatest at the midline because that's really where sonic hedgehog gets going. And then as they propagate to other centers, you have a smaller findings in the kind of less severe cases. Now, we may say fusion a lot, but really it's the failure of induction. And as we saw with the eye, it's not that the eyes fuse, but they failed to split. And that's how we should see these, is that we may think that these structures are in fact fused, but they failed to separate. So really it's an apparent fusion of the midline structures. And again, they're graded on a severity scale from alobar being the most severe to semi-lobar being partial apparent fusion, or usually in the rostral or ventral components, and then less severe in the back, and then lobar being the least severe, as we'll see, with some fusion or apparent fusion of structures, but less severe. And we'll see how those are defined shortly. Craniofacially, a cyclopia is the one that we saw with the lamb. It's also found similarly in the human disease, single orbit with a single eye, and then you have this proboscis, which is the nasal structure being formed above the eye, and because the eyes didn't split, they didn't have the chance to migrate to go laterally and migrate upwards, as we see in their final anomaly. A less severe form is called ethmocephaly. There is separation of the eyes, but they're placed fairly close, and the proboscis now is in the middle. So a little bit less severe. And then there's something called sebocephaly, which is a little bit less severe, where you have ocular hypotelorism, so their eyes are fairly close together, and then you have a nose in its correct position, but you have a single nostril with and without a cleft lip or palate. And then usually you only have a single central incisor in the middle instead of two. So and then of course the less severe form is the microform one, where you have abnormal facial structures, but the brain is fairly normal otherwise. And when you see this, you want to think of a genetic carrier, right? So just because the phenotype will be relatively less severe, it doesn't mean that their offspring will have less severe symptoms because of the variable penetrance. They could have someone with very severe alobar holoprosencephaly. It's just that in their particular case, it didn't manifest as severe findings. Here, just some more kind of images just to see the spectrum in its entirety. We have that sebocephaly with those hypotelorism and single nostril on the nose. We have the cleft palate in the second picture, and then we have the cyclopia and the proboscis in the third picture in a patient with trisomy 13. So pathology, this is really a macroscopic diagnosis with the ventral structures being more severely affected than the posterior structures. And that will help you try to grade it into one of these three categories. And interestingly, of course, it's consistent with the sonic hedgehog gradient being that ventral midline initiating morphogen. Olfactory bulbs are usually absent in virtually all cases. In the alobar and semi-lobar forms, the brains are particularly small, right? they never form those telencephalic vesicles that generate the majority of our cerebral cortex. It's this prosencephalic structure that really cannot create the same sort of cortical mass as the telencephalic vesicles. The main way you classify these is with the interhemispheric fissure, that big fissure that goes across the midline from anterior to posterior. In A lobar, it's completely gone. Okay, you have a single holosphere with the hemispheres looking fused, and you have a monoventricle on imaging. And this is what these two pictures show: a 20-week gestational age fetus having this kind of horseshoe-shaped mono holosphere with a monoventricle. This is an interesting case because it's an adult case, which is, as we said, very rare. Usually these fetuses die shortly after birth, but you can see a very clear monoventricle, a thin white matter around it, signifying low, gray cortical mass around the brain. And that's the most severe form. We don't see an interhemispheric fissure. Usually, there's no surface anatomy. Gyral patterns may form depending on the age. As the older these patients get, they will develop some gyral structures, but definitely slower than expected. And when they do form, they're abnormal. As we talked about, there's a horseshoe-shaped structure, and as we'll see with the semilobar form and many other pictures, there's this cystic, delicate membranous roof in the forming a dorsal cyst, and I kind of think about it as that very thin layer of the very top of the neural tube that never got outgrown with the telencephalic tissue surrounding it. The basal ganglia have this apparent fusion with the monoventricle. There's usually an absent corpus callosum. Other midline structures like the falx and the sagittal sinus are also gone. There's minimal white matter because of the lack of coordinated neural migration and kind of population of that cortical plate to form the mass of the cerebral cortex. And you have hypoplastic cortical spinal tracts if you can find them. In the semi-lobar form, we see that there is a interhemispheric fissure, but only on the back. This is a 19-week fetus seen from the back. And then you can see in the front, it's kind of completely gone. And you have disorganized gyral patterns and milder microcephaly, right? So even this term fetus seems to have more gray matter than this adult case. And then you see fusion of the basal ganglia. And even though there's an interhemispheric fissure here, you kind of get the sense of a single ventricle. In the lobar form, you have that interhemispheric fissure running almost the entirety of the cortex. But even on sectioning, you do see some fusion of the basal ganglia, and then the frontal fusion shown here is also apparent, even though there was an interhemispheric fissure. So again, the brain is usually a normal size in this case. Perhaps there was some telencephalic development, but just not complete or delayed. But this is more of a spectrum than a kind of categorical group. So just keep that in mind. So here's some more pictures showing this holoprosencephaly of this 17-week-old. This is an alobar form. We don't see any interhemispheric fissure. We see this horseshoe-shaped cortical structure. It's very, very small, and there's abnormal vessels running along the base part of the brain. Dorsally, there's this dorsal cyst, which again, I kind of think of it as this structure here. If this did induce properly and form this telencephalon, that would kind of just outgrow this cystic structure, and this would be kind of engulfed in the middle of the brain. but since it's not forming, you have this dorsal cyst that's formed. So a very common component of this disease. So here again is another picture of an alobar holoprosencephaly, fused holosphere with minimal gyrations, no olfactory structure seen here from the bottom, and very, very small, 150 grams at 18 months, microcephaly. And interestingly, the cerebellum appears to have formed quite normally. So this is really a forebrain neurodevelopmental issue. It's not just sonic hedgehog, because sonic hedgehog is important for cerebellum development. It's really the coordination of those three major morphogens that's the issue. Again, looking at it from the back, we have this dorsal cyst structure. Here it's been penetrated, and you can see a monoventricle and a fused basal ganglia here, and then hydrocephalus with a very thin pallium when you section it, indicating that really that the cortical plate did not form well in this microcephalic brain. Another case of alobar holoprosencephaly. This one has some gyral patterns. They look abnormal. They don't really fit the expected case here. And then in that back, they extend all the way in the back, and then there is a kind of this dorsal cyst thin membrane structure that we've now seen a couple of times. You can see here, sectioning it shows the fused basal ganglia and a single ventricle, and no interhemispheric fissure that's consistently seen down the midline. Here's a very profound case of microcephaly and alobar holoprosencephaly. So this presumably is the prosencephalon, and this is the basal ganglia here. Very, very little cortical tissue. Here's some hippocampi that are being formed, and you can see this is the lining, which is an ependymal lining, which is what would line the neural tube, and the stub here just looks like disorganized neural tissue. So this is a semi-lobar holoprosencephaly. You see maybe an interhemispheric fissure along the back here that's absent from the front, and then just very rudimentary gyral patterns in both cases. Perhaps here there are some temporal lobes seen on either side, but definitely not the size and recognizable gyral patterns that we expect from a brain. So we have an interhemispheric fissure, we have fused basal ganglia, and perhaps a monoventricle here. This is shown better here, and there is some evidence of a interhemispheric fissure. Now, this is going to be interesting. We're going to see this again in probably the next picture here, but we have the gray matter crossing the midline. Usually, there's no gray matter in the midline. Usually, the two hemispheres are being held together by the corpus callosum, but in this case, we have the it looks like we have tissue on crossing the midline, and there's a name for that, as we'll see. So this is a lobar case. There is some fusion, but perhaps there is a hint of an interhemispheric fissure seen on the outside. There are some gyral patterns, but and they look, quite recognizable. Here is the interhemispheric fissure. We see kind of a resemblance of two ventricles here, with a third ventricle in the middle. Temporal lobes. But again, you see here that there is the cingulate cortex is running across the midline, which is very abnormal. If you go back, or if you go to the front, or the back in this case, there is some fusion. So not a perfect separation throughout, which is why it's not normal and part of the holoprosencephaly spectrum. So this thing here that we're seeing, The cingulate gyrus crossing it is called cingulosynapsis. And on microscopic appearance, we have these kind of polymicrogyria-like undulations of the cortical ribbon, which again just indicate that this is not normal cortex. While there are some reports of different migrational abnormalities that accompany the microscopic appearance of these specimens, these are, kind of controversial. There's not a lot of cases. They're sometimes reported, sometimes not. So it's not a requirement. Really, the gross is the main diagnostic findings, but not unreasonable to expect that this failure of midline induction is going to lead to abnormal cortical plate migration and subsequent set architectural patterns seen on microscopic exam. But again, the key is that these are not essential. This is an examination, a diagnosis on gross exam. So pathogenesis, as we mentioned, this is a failure of midline induction stemming from defective morphogenic signaling, whether it be the production, the reception, the transduction, and or the interpretation of the sonic hedgehog signaling. You need cholesterol with sonic hedgehog. You need it to bind to the patch receptor and inhibit its inhibitory effects of the smoothen pathway, which again will activate these GLI transcription factors. This can occur at any stage. It can occur, early on with the notochord and nodal signaling. It can occur with sonic hedgehog signaling later on, or even other factors such as SIC3 that are important for this coordinated passing of the baton of the sonic hedgehog to the FGF8 to the BMP signals. So the key is that because of the sonic hedgehog signaling being so critical, really the midline structures where things start are usually much more effective than the posterior structures when there's mild defective signaling, because it'll affect the areas that are predominantly driven by sonic hedgehog, but perhaps just a little bit or enough sonic hedgehog signaling will help some of the FGF and BMP pathways lead to some resemblance of some telencephalic development. Importantly, sonic hedgehog is also a key part of the precortal mesoderm, which is important for midline craniofacial development, and this may link the forebrain and with the craniofacial defects. But this link is somewhat, not fully finalized or well understood. So just keep that in mind. Interestingly, all the four major genes that are shown here in red, if you delete them in animals, you get HPE-like phenotypes. And of course, cyclopamine, which acts on the smoothen receptor, also gives you similar defects as well. TGIF really disrupts the sonic hedgehog nodal signaling, and ZIC2 leads to defective node precortal plate development, impacting sonic hedgehog and nodal signaling. So as you can see, these transcription factors are really affecting the pathways in different ways. And again, cholesterol is key, with disruption in cholesterol being an important alternative pathway to disrupt the sonic hedgehog signaling. So let's shift gears now to atelencephaly and aprosencephaly. This is an interesting disorder because it's so rare, so not much is understood, but it has some features similar to both holoprosencephaly and anencephaly, which we saw with the neural tube defects, is when the neural tube is degenerated by exposure to amniotic fluid. There's two forms. There's atelencephaly, which is absent telencephalon with a residual diencephalon, and then there's aprosencephaly, which means that both structures of the prosencephalon are affected, both the telencephalon and the diencephalon. And really, it's, again, this is a continuum. it's easy to categorize it based on these embryological principles, but really it's a continuum. It's extremely rare, so make what you will of the evidence. It's not well understood, and there's probably multiple things going on based on the things that I've read. So it's usually sporadic, but some link to chromosome 13 have been documented. And again, chromosome 13 is really special because it's the one that's affected in holoprosencephaly. So is this a severe form of holoprosencephaly or a different disease? That's up for debate, but it's why they're grouped together. Interestingly, one family that's been reported had mutations in SIK3, kind of, again, supporting a potential continuum with holoprosencephaly. So general pathology, other organ systems are commonly affected. There's ventricular septal defects, atrial septal defects, patent ductus arteriosus, coarctation of the aorta. You know, I'm not a cardiovascular pathologist, but those sounds like, they could potentially compromise blood flow to other organs of the body. There's some hypoplasia, olidactyly, clubfoot, which again, is this a destructive disorder or a failure of midline patterning? I think that part hasn't been figured out. Obviously, cyclopia and coloboma, hypertaylorism, these kind of sound similar to what we've been seeing with holoprosencephaly. So perhaps in some cases, it may be an extreme form of holoprosencephaly. It's usually lethal. You get a blunted stub on neuropathology of forebrain tissue that includes telencephalic derivatives, cerebral hemispheres, basal ganglia, and ventricles are virtually absent. But the calvarium is intact, right? So that's a big distinction from anencephaly, and so is the skin. So there is some key differences that will help you differentiate this from anencephaly, where the skin is degenerated, the skull is not formed, and the brain is actually exposed to amniotic fluid, which is not the case here. Histology, you have disorganized gray matter, white matter, you have immature tissue, and then calcifications and angiopathies, may suggest some destructive component in some cases. But again, there's just so few cases that it's very hard to make sense of what exactly is going on. Interestingly, the hindbrain, again, is relatively well preserved. And so it is a kind of a defect of the prosencephalon. So here we have microcephaly, we have an intact skin and this abruptly sloping cortex. And then when you section it, there's basically absent cerebral hemispheres. And in this case, you have two basal ganglia that are not fused. So again, very variable disease with its rarity, hard to make sense of what's going on. Here's another case, extreme microcephaly. And then when you section it, you have this kind of globular cortex with no cleavage or olfactory nerves, but an optic chiasm seen here at the bottom. And then there is some sort of midline white matter seen across. But otherwise, very homogeneous tissue. There is some symmetry in this case with some myelinated fibers. And then in this case, there is some ventricle at high power where you see a ependymole in the midline, suggesting that there is some ventricle or formation. But usually what you see is this polymicrogyric cortex with this kind of undulating ribbon of cortex, four-layered structures, usually thick mesoglial, mesodermal glial tissue surrounding the brain tissue, but abnormal development for sure. Some things may come to mind on a differential anencephaly. Think about hypoplastic skull covering the skin. as a differentiating factor. And then destructive process, you can look at the kind of skull brain disproportions to kind of help decipher that in some cases. If you have a very large skull but a small brain, maybe perhaps if there was some destruction at some point in utero. But of course, if the destruction happened early on, this may not be there may not be disproportions. Again, not always clear black and white. So really, that's where things stand with those two conditions. So let's move on to agenesis of the corpus callosum. This includes absence, complete absence, partial absence, or thinning, and can occur in the absence or part of other conditions such as holoprosencephaly, septic optic dysplasia. It's usually syndromic. About 80% of cases have other CNS abnormalities. 62% of cases have extra CNS abnormalities, but it can occur in isolation. There's a lot of genes and syndromes associated with this condition. But interestingly, again, for our discussion, some of these genes include FGF8, ZIC2, and SIX3, which, as we mentioned, are part of those midline patterning defects. Perhaps this could be on the very mild spectrum of a midline induction defect. Clinically, in isolation, it could be silent or subtle. With patients only having pathology and very kind of intricate neuropsychological testing. Yeah, nonetheless, it is associated even in isolation with increased incidence of seizures, mental restriction, and other migrational disorders. Can be diagnosed on prenatal ultrasound or incidentally later on in life if isolated. I'm going to show some pictures. Some are interesting because they're associated with other pathologies, which may be kind of physical components and not entirely kind of biological from the midline patterning component. So there are some other non-patterning defects that may cause agenesis of the corpus callosum. In complete agenesis of the corpus callosum, you could have absence of cingulate gyri. That's a helpful feature if somehow you're not sure if they've been severed. And usually the ventricles kind of radiate upward and form this bat-like wing type of description. So yeah, ventricle is slightly enlarged with a bat wing appearance. And the other feature that's very critical that can help you is this bundle of props, which are basically misdirected white matter tracts where the corpus callosum should be, right? So, well, this is important later as we'll talk, but notice that the two hemispheres are usually just connected by the corpus callosum. So if you don't have that structure, there's really nothing holding the two hemispheres together once the brain leaves the skull. There's partial agenesis of the corpus callosum, which usually you have a corpus callosum in some parts of the brain and other parts you don't. This usually has a predominance for the posterior corpus callosum being affected, with the rostral components being preserved. So the opposite version of severity to the holoprosencephaly. That's going to be important if you're not sure if this is an isolated event or part of a subtle holoprosencephaly. You can look at the two to see if they follow this opposite kind of form. And the cingulate in these partial cases is usually present where the corpus callosum is formed. Differential, you need to figure out if it's isolated versus syndromic. Syndromic cases need proper workup for other more severe metabolic disorders such as Zellweger syndrome, Smith-Lemmy-Opitz syndrome, and then look to see if there's a stigmata of other kind of neurological disorders where these types of features are found. Usually with these holoprosencephaly, because it's a different mechanism, they lack the props bundles. The presence of props bundles suggests more of an isolated agenus of the corpus callosum more than a holoprosencephaly variant with absence of the corpus callosum. And again, look for secondary destruction. Usually, if it's a secondary destruction, you're going to have a cingulate gyrus because it formed. And then there's going to be a lack of that bundle of props. Here is a case where there is a lipoma. The corpus callosum seemed to have formed anteriorly, but if you go posteriorly, you see that the lipoma prevented these fibers from crossing. So it's more of a physical mechanism of action with the white matter tracts forming this bundle of props there. And the cingulate seems to be more prominent in the areas where there is a good corpus callosum than posteriorly, where it seems to be a little bit more difficult to appreciate. Here's another case where you have agenesis of the corpus callosum due to unilateral mass. You have this large enlarged left hemisphere, which has this gray matter heterotopia. And this, I guess, prevented proper migration of the axons to the other side. And then you have this bundle of props here with on the right side that appeared to develop quite normally. So another kind of case where perhaps another neuropathology led to the agenesis of the corpus callosum. Here is some other examples where perhaps it's more isolated. You have complete agenesis of the corpus callosum. You have no cingulate gyrus here. And then you have these gyral patterns going vertically, which is very abnormal. And then here is a partial case where the cingulate gyrus is being formed just in the area where there is a corpus callosum. So a partial case with a partial cingulate gyrus over the partial white matter tract. And there's your bundle of props seen on histology. Another nice case here in a 3-month-old with maple syrup disease. You can see absent corpus callosum, absent cingulate gyrus, and then on cross-sectioning, you have these bundle of props, which is the misdirected fibers. You can also see these kind of anterior bat winging of the ventricles, which is another kind of sign that can help you clinch the diagnosis. And yet another case here where no cingulate gyrus, no corpus callosum, and then you have these bundle of props, and maybe it's this thing here, and these kind of upgoing ventricles. So as I mentioned, really, the two hemispheres are being held by this corpus callosum. So if this corpus callosum doesn't form, when you do this autopsy early on or even later on, you see this kind of cyst roof of the third ventricle being formed, basically, because nothing is holding those telencephalons together. And this microscopy just shows a very nice membrane, which is fibrovascular and ependymal tissue, just holding these delicate cerebral hemispheres together. Embryologically, the corpus callosum is formed in the commissural plate, which is a thickening of the lamina terminalis, which is basically the most rostral part of the telencephalic midline. So this is the roof of the prosencephalon, the lamina terminalis here. This is the telencephalon being formed here. And this is going to thicken itself and form this this commissural plate. And that really is going to be where these axons cross the midline from one telencephalon to the next and form these commissures. The corpus callosum, the anterior commissure, the hippocampal commissure with the fornix. They all form in this lamina terminalis. These happen very early on, as we saw. Day 45, you start getting these axons already crossing the midline. And really the key is here is that part of the key for this is that there are some midline signals and morphogens that are being secreted that help with axonal guidance. There's specialized glial cells that form these glial slings or glial bridges that also help direct axons across the midline. And so if you have a defect in how the midline is being patterned, these signals and cells may not be there, and therefore it really is just a very mild form in one interpretation of a midline patterning defect. Again, as we mentioned, this begins rostrally to caudally, which explains the kind of the observations of partial agenesis of the corpus callosum, and then the remainder of this lamina terminalis becomes a septum pellucidum. So again, we'll see that with the next disorder, septic optic dysplasia, but really the septum pellucidum is just the residual lamina terminalis. Genes involved in holoprosencephaly, FGF8, ZIG2, SIG3, may affect these kind of glial populations we discussed, which impacts the attractive and repulsive forces for these callosal fibers. So here's just this in a cartoon form. Think of this as the lamina terminalis there in the middle. It's going to secrete some factors, and then the axons are going to cross through and really bridge together those two hemispheres. So it's very, very important for the integrity of the final product to have those axons crossing the midline. And then this just shows, again, the rostral to caudal sequence of development of the corpus callosum, which you will see in partial agenesis of the corpus callosum. Here's a septum pellucidum, which is basically just, when this is all said and done, that's the final product. The residual lamina terminalis will become the septum pellucidum. So finally, septic optic dysplasia. This is defined as a triad of aplasia of the septum pellucidum, optic nerve hypoplasia, aplasia, and hypoplasia or dysplasia of the pituitary gland. And usually you don't get all three in the same patient. Usually most patients have two of three. And so you don't need the full triad to make this diagnosis. Can be isolated or syndromic, highly variable and heterogeneous, just like the other disorders. And genetics, why are we grouping these things together? There are similar genes such as FGF8 implicated in this disorder that we saw also affect holoprosencephaly in patients with agenesis of the corpus callosum. So clinical features depends on which aspects of the brain are affected. Optic nerve hypoplasia, you're going to have visual impairment, again, to a severity based on the degree of hypoplasia. You can have endocrine abnormalities depending on the degree of pituitary hypoplasia, hypoglycemia, diabetes, growth defects. And so those are going to be the major clinical signs. There's probably not too much of a clinical feature of agenesis of the septum pellucidum. So that's why it's not included as one of the clinical features. So here we have olfactory aplasia, hypoplasia, as we saw with many of these disorders. But here the important thing is you have hypoplasia of these optic nerves, perhaps this one more than that one, which is going to lead to visual impairment. And then on sectioning, you have loss of the septum pellucidum in a very thin corpus callosum here. So very rare cases. I struggled to find examples of these cases to show you guys. So optic nerves may be small or absent. Hypoplasia of the lateral genicular body, genicular nucleus. I've only seen that in one textbook, and they said even there it's fairly rare. You can have dysplasia of the hypothalamic nuclei. Again, these are midline structures around the ventricles. Olfactory aplasia, which we've seen commonly across these disorders we've talked about today. Pituitary may be present, is usually present but small, and the cerebral cortex is usually normal. Embryologically, again, probably defects in linked to the midline patterning with some mouse models where you have sonic hedgehog loss in the midline showing septic optic dysplasia. this with the FGF8 that has been reported in some cases really links that midline patterning morphogenic signaling to this disease. So we'll stop there. Thanks so much for listening. Hopefully that was useful. Lots of material, but hopefully we developed a strong framework with the embryology that these disorders become more intuitive of how they're linked together and how the neuropathology manifests by defects in this midline signaling. Thank you very much.